Usually when a patient walks into the clinic holding their shoulder and wincing in pain, you immediately think, okay, rotator cuff tear, or maybe some severe osteoarthritis.
Right, yeah. You're looking for a localized physical problem right there in the joint.
Exactly. You start mentally preparing to break out your musculoskeletal exam skills. Or, you're probably already thinking about a physical therapy referral.
Or prepping for a steroid injection.
Yeah. And if, while you're talking to them, you happen to notice their eyelid is dripping on that same side, you might pause and think, oh, that's weird. Maybe they had a TIA a while back.
Sure, or some isolated cranial nerve issue.
Right. But you definitely don't look at a sore shoulder and a droopy eyelid and immediately jump to lung cancer.
But today, that is the exact leap we need to make. We are stepping entirely out of those neat little diagnostic silos.
I am so ready for this. I am fully in PA student mode today, and I know a lot of you listening are getting ready to crush the PANCE or PANR. So we are incredibly lucky to have our ultimate clinical educator here at the study table.
Happy to be here.
We're taking a deep dive into some of the trickiest, most high-yield pulmonary manifestations you'll see on the boards, and, well, out in real-world practice, too.
Yeah, we have a really clear mission for this deep dive. By the end of this session, you are going to master 3 specific things. First, pattern recognition for Pancoast tumors.
Okay, love it.
Second, you'll learn exactly how to identify and manage Superior Vena Cava syndrome, or SVC syndrome. And third, we are going to untangle some incredibly deceptive autoimmune mimicry by differentiating Lambert-Eaton myasthenic syndrome from other neuromuscular conditions.
It sounds like a lot, but we're going to break it all down. And we're going to do all of that by tracking one specific patient case throughout this entire deep dive.
Right. Think of this as a real-time clinical reasoning exercise. Let's introduce our anchor case so you can picture him.
Okay, picture a 65-year-old male. He has a heavy smoking history, let's say 40 pack years. He comes into your clinic complaining of severe, unrelenting right shoulder and arm pain.
Classic presentation.
Yeah, and almost as an afterthought, his wife mentions that his right eyelid has been drooping lately.
So right away, that is such a tempting clinical trap.
It really is. Shoulder pain plus a droopy eyelid feels like he needs to see orthopedics and maybe get a neuroconsult. Like, why are we even talking about pulmonology?
Because the answer is hiding in the anatomy of the lung apex. And that brings us to the first major pattern you need to recognize, which is the superior sulcus tumor, commonly known as a Pancoast tumor.
Okay, let's orient ourselves really quickly. When we say superior sulcus, we're talking about the very top of the chest cavity, right? Like the absolute peak of the lung.
That's the exact spot. And here is a crucial high-yield board pearl. The diagnosis of a Pancoast tumor is determined entirely by its location, not its histology.
Wait, really? So any tumor up there is a Pancoast tumor?
Exactly. Any tumor sitting up there gets the name. However, if we look at the statistics, over 95% of these are non-small cell lung carcinomas, or NSCLC.
Okay, got it.
And usually you're specifically looking at the squamous cell subtype.
So we have this squamous cell mass sitting way up at the apex. But how does a mass in the lung explain the fact that his shoulder is killing him and his eyelid is drooping?
Well, think about the real estate up there. It is incredibly crowded. Because of where the tumor sits, as it grows, it simply runs out of room.
So it can't grow down into the rest of the lung easily.
Right, so it pushes up and out, physically compressing the structures above it. Specifically, it crushes the lower brachial plexus, mostly the C8, T1, and T2 nerve roots, and the ulnar nerve.
Oh, wow. Okay, if you're compressing the C8 to T2 dermatomes, that shoots pain right across the shoulder, down the arm, and into the hand.
Exactly. He's not having joint pain. He is having radiating nerve pain.
But here's where my mind gets tripped up, and I know this is a massive pants trap for a lot of you listening. Whenever we learn about lung cancer, the illness script always starts with a chronic cough, or, coughing up blood, hemoptysis.
Right.
But our guy doesn't have a cough.
Which is exactly why students get fooled. Because Pancoast tumors are peripheral, meaning they're at the extreme outer edges of the lung tissue, far away from the major central airways.
Oh, that makes total sense structurally. If the tumor isn't irritating the main bronchi, you aren't going to cough.
Precisely. Classic pulmonary symptoms, like a cough or shortness of breath, are actually incredibly uncommon early on. They won't show classic lung signs until the disease is highly advanced.
So the most common initial symptom is just that shoulder and arm pain.
Yep. You might also notice ulnar neuropathy, like numbness in the pinky finger, or even weakness and visible atrophy of the intrinsic hand muscles if the nerve has been compressed long enough.
Okay, that perfectly explains the arm, but what about the drooping eyelid? The wife specifically pointed that out.
That brings us to the second structure getting crushed up there, which is the cervical sympathetic nerve chain. When that happens, you get Horner syndrome.
Right, Horner syndrome.
It's a classic triad you absolutely must commit to memory for the boards. First, ipsilateral mitosis.
Which is the drooping eyelid on the same side as the tumor.
Exactly. Second, meiosis, which is a constricted pupil on that side. And third, anhidrosis, which is the lack of sweating on that side of the face.
Okay, let me repeat that to lock it in. Ipsilateral mitosis, meiosis, and hydrosis. Because the sympathetic nervous system essentially runs our fight-or-flight response, right?
You've got it.
Which includes keeping our eyes wide open, dilating our pupils to see threats, and sweating to cool down. If the tumor crushes that nerve chain, all of those functions just drop offline on that side.
You got the mechanism down perfectly. Though, interestingly, before the nerve completely dies or gets fully compressed, it can actually get hyperirritated.
Oh, really?
Yeah. So before the anhidrosis sets in, the patient might actually have ipsilateral facial flushing and diaphoresis, which is excessive sweating, on that side.
Wow, that is a brilliant little nuance. Okay, let's pause here and put you, the listener, in the hot seat for a second. Let's do an interactive pause.
Good idea.
We're back in the clinic. You recognize this pattern in our 65-year-old smoker. Shoulder pain, droopy eyelid, no cough. You suspect a Pancoast tumor. What is the very first imaging test you order? And then what is the better test to see how bad the damage is?
Walk us through the clinical reasoning on that.
Well, the initial test is always going to be a simple chest radiograph,
Right.
a chest x-ray. It's fast, it's cheap, and it'll show you if there's a big asymmetrical mass sitting at the lung apex.
Right. But an x-ray won't tell you the whole story.
Exactly. It won't tell you if the tumor has invaded the nerves or the chest wall. So the better test to assess the extent of infiltration into adjacent tissues is an MRI.
That is the exact sequence they want to see on the boards. And if you need to get a tissue diagnosis to confirm it's squamous cell.
Well, because it's peripheral, way out at the edge of the lung, navigating a bronchoscope all the way down there from the inside is really difficult. So a core needle biopsy through the chest wall is generally preferred for histology.
Spot on. Now, regarding management, let's delineate the absolute must-know baseline from the higher-level bonus knowledge.
Okay, for the must-know baseline, if the disease is resectable, meaning it hasn't metastasized and we can safely cut it out, the standard initial step isn't actually just surgery.
Correct.
You start with concurrent chemoradiotherapy to shrink the tumor and pull it away from those critical nerves and vessels. Then, if there's no progression, you follow up with surgical resection.
And for the students wanting to score in the top percentiles, what's the newest addition to that regimen?
This is a great piece of bonus knowledge. Adjuvant atezolizumab. It's an immunotherapy drug now used for patients with stage 2 to 3, a non-small cell lung cancer, specifically if their tumor expresses PD-L1 at 1% or higher.
That's excellent. We've just seen how a tumor at the apex acts as a physical space occupier, crushing nerves. But let's rewind our anchor patient's timeline and change the scenario.
Okay, let's pivot.
Let's say he didn't develop an apical squamous cell tumor. What if he developed a lung tumor that decided to set up camp centrally, right in the middle of the mediastinum?
Well, if it's centrally located, it's not going to compress the brachial plexus, so no shoulder pain. But it is sitting right next to the major plumbing of the heart. Which brings us to our second topic. Superior Vena Cava syndrome, or SVC syndrome.
This is a major shift. While Pancoast tumors are almost always non-small cell lung cancer, small cell lung carcinoma, or SCLC, is the undisputed king of paraneoplastic and systemic manifestations.
That's a great distinction to make.
Small cell is the most common solid tumor to present with SVC syndrome.
Okay, that makes sense. Small cell lung cancers are aggressive, central tumors. But just to clarify the etiology, SVC syndrome can also be caused by non-Hodgkin lymphoma, or even on malignant things like a thrombus from a central venous catheter causing stenosis, right?
It can, absolutely. But small cell lung cancer is the classic board presentation. So let's build an illness script. Walk me through what happens when a central tumor physically crushes the superior vena cava.
Well, the superior vena cava is the massive vein responsible for draining all the deoxygenated blood from the head, neck, and arms back into the right atrium of the heart.
Right.
If a tumor clamps down on that vein, the blood literally has nowhere to go. It just backs up like a massive traffic jam.
So what are you going to see when that patient walks into the exam room?
You're going to see severe swelling, facial edema, neck edema, and swelling in the upper arms. You get what's called facial plethora, which is this red, flushed, engorged appearance because the blood is just pooling there.
Yeah, it's very striking visually.
And the body is smart, right? It tries to find detours. So on physical exam, you'll literally see dilated, prominent collateral veins snaking across their chest and neck.
That is the visual. But what is the most common symptom they will actually complain of?
Shortness of breath, dyspnea.
Right.
Which is logical if you think about it. You have all this fluid backing up, which causes edema in the mucosal tissues of the airway itself. Plus, you have a giant central mass that's likely pressing directly on the trachea or the main bronchi.
Exactly. To diagnose it, a chest radiograph might show a widened mediastinum or a right hilar mass. But just like with the Pancoast tumor, you need better visualization.
So we go to CT.
Yes, a contrast-enhanced CT scan of the chest is the gold standard here. It assesses the exact degree of the venous obstruction and shows you the collateral blood flow.
Okay, let's put the listener back in the hot seat for another interactive pause. This is a high-stakes emergency scenario.
Let's hear it.
You are in the ER. Our patient comes in with a deeply flushed face, bulging neck veins, and a widened mediastinum on X-ray. Classic SVC syndrome. But here's the twist. He is struggling to breathe, and you hear severe stridor.
Oof, okay.
Yeah, that high-pitched, harsh wheezing sound means his laryngeal tissue is so swollen, his airway is about to completely close off. You do not have a tissue biopsy yet to confirm it's small cell cancer. What is your very first move?
This is a phenomenal scenario because clinical dogma clashes with emergency reality here.
Right, because the golden rule of oncology is histologic diagnosis is required prior to initiating specific anti-tumor therapy. You never want to radiate or give chemo to a cancer if you don't know exactly what type it is.
No.
But if a patient has life-threatening symptoms, like stridor from central airway obstruction, severe laryngeal edema, or depressed neurological function because their brain is swelling from the fluid backup, you throw that rule out the window.
You absolutely do. You do not have time to wait for pathology. You have to rely on your ABCs. Airway, breathing, circulation.
Exactly. You secure the airway first, intubate if necessary, and then you need immediate endovenous intervention. We're talking about getting in there right away for a mechanical thrombus removal or placing a vascular stent to force that vein back open and restore blood flow.
Fix the plumbing immediately to save their life.
Yes, and then you worry about biopsying the tumor later.
That distinction will absolutely be tested, so mark that down. Now let's pivot again. We've talked about a tumor physically crushing nerves and a tumor physically crushing a vein, but earlier I mentioned that small cell lung cancer is the king of paraneoplastic syndromes.
Right, where the damage isn't from physical compression at all.
Exactly, it's from friendly fire. The body's immune system gets confused and attacks the patient. Let's rewind our anchor patient one last time. Months before he ever had shoulder pain or facial swelling, he was sitting in his favorite recliner at home, and he realized he just didn't have the strength to stand up.
That is the perfect introduction to Lambert-Eaton myasthenic syndrome, or LEMS. Such a tricky neuromuscular imposter.
Let's break down the pathophysiology. Why is his body attacking him?
Well, small cell lung cancer cells express certain antigens, right?
Right. And the body's immune system detects them and mounts a defense, creating antibodies to fight the tumor. The problem is those antibodies cross-react. They mistake the body's own presynaptic voltage-gated calcium channels at the neuromuscular junction for the tumor.
Oh, wow.
So they attack and block those calcium channels.
Okay, let's walk through that mechanism. If antibodies block the calcium channels on the nerve ending, well, calcium can't enter the nerve. And calcium is the trigger that tells the nerve to release acetylcholine into the junction. Which means the nerve never drops the acetylcholine payload. The muscle never gets a chemical memo to contract, resulting in profound weakness.
Exactly.
Now, this is where the illness script compare and contrast is vital. LEMS sounds incredibly similar to myasthenia gravis. Both cause weakness. How do we tell them apart?
I like to use the rusty gate analogy. In LEMS, the calcium channels are like rusty gates. They're blocked by antibodies and very hard to open.
Okay, so if the gate is rusty, resting strength is going to be terrible.
Yeah.
But, and this is the golden rule that feels totally backward, in LEMS, proximal muscle weakness actually improves with repeated muscle use.
Think about why that happens based on the analogy.
If you repeatedly stimulate the nerve, like if you keep pushing and shoving on that rusty gate by trying to move the muscle calcium, gradually builds up enough inside the nerve terminal to finally force the release of acetylcholine.
Yes.
So paradoxically, as they exercise the muscle, they get momentarily stronger. That is the complete opposite of myasthenia gravis, where repeating a movement depletes their receptors and makes them weaker.
You nailed the mechanism. So clinically, these patients complain of difficulty rising from a chair or walking upstairs. The weakness typically progresses from proximal to distal.
So it starts in the core and thighs and moves out to the hands and feet.
Right, and it moves caudal to cranial, from the legs up toward the head.
Aside from the weakness, what else are we looking for in the physical exam?
You'll see hyperreflexia, which is diminished or absent deep tendon reflexes. You might notice their pupils are sluggish to respond to light, but crucially, you will not see significant muscle atrophy.
Right, because the muscle tissue itself is perfectly healthy. It's just dealing with a bad cell surface connection. We also can't forget the autonomic symptoms.
True.
Acetylcholine isn't just for moving your biceps. It's the primary neurotransmitter of the parasympathetic nervous system. So if it's blocked, you get autonomic dysfunction. The most common symptom is a profoundly dry mouth. They can also suffer from postural hypotension and erectile dysfunction.
Let's put you back in the hot seat for diagnosis. One last interactive pause.
Bring it on.
You suspect LEMS in our patient. You draw blood for a voltage-gated calcium channel antibody assay, which comes back positive in about 85 to 95% of cases. But you also order a specialized electrophysiology test, repetitive nerve stimulation, or RNS. What exactly does the RNS show that confirms the rusty gait theory?
Okay, logically, when you first stimulate the nerve at rest, the compound muscle action potential, the CMAP amplitude, is going to be very low because the gates are stuck closed.
Right. And then you have the patient exercise the muscle for a few seconds.
After exercise, you see a reproducible post-exercise increase in that CMAP because the calcium built up and forced the gate open.
Exactly.
Furthermore, the rate of the shock matters. At low rates of repetitive stimulation, the response dips. It's decremental. But at high rate stimulation, you see an incremental response. The faster you hit it, the more the calcium accumulates and the stronger the electrical reading gets.
That is the defining diagnostic hallmark. Plus, once you confirm LEMS, you are immediately ordering a CT or MRI of the chest to hunt for the underlying small cell lung cancer that triggered it in the first place.
So how do we treat the LEMS?
The primary goal is always to treat the underlying malignancy, cure the cancer, remove the trigger for the antibodies. But for symptomatic management, we use medications like amifampridine.
How does that work?
It blocks potassium channels, which essentially prolongs the nerve's depolarization, giving those rusty calcium channels more time to open. We also use pyridostigmine, which stops the breakdown of whatever acetylcholine does manage to get into the junction.
And if those first-line meds don't work?
Then we look at more aggressive interventions. Plasmapheresis to literally filter the rogue antibodies out of the blood, IVI, or long-term oral immunosuppressants.
Man, this has been an incredibly dense, high-yield session. We've connected a lot of dots. Let's shift gears and synthesize all of this with a rapid-fire recap, and then test it with some board questions.
Let's do it.
For the big takeaways. First, Pancoast tumors. These are apical tumors, over 95% non-small cell lung cancer. They present with shoulder and arm pain radiating down the C8 to T2 dermatomes and Horner syndrome, which is ptosis, meiosis, anhidrosis.
Find the trap.
The trap is there's usually no initial cough. Second, Superior Vena Cava syndrome. Small cell lung cancer is the biggest culprit. Look for the backed up plumbing. Facial swelling, plethora, dilated chest veins, and shortness of breath.
And the trap there.
If their airway is collapsing with stridor, you stabilize the airway and place a vascular stent immediately. Do not wait for a biopsy.
Perfect.
Third, Lambert-Eaton myasthenic syndrome, another small cell paraneoplastic condition. The immune system attacks the presynaptic voltage-gated calcium channels. The hallmark trap here is that it causes proximal weakness that paradoxically improves with repeated use, often paired with a dry mouth and hyperreflexia.
That is a phenomenal summary. Now let's lock this in. I'm going to read 3 board-style multiple-choice questions. If you're listening, try to answer them in your head before our host breaks them down. Ready? Question 1. A patient presents with right-sided ptosis, a constricted right pupil, and a lack of facial sweating on the right side. A chest radiograph reveals a large mass at the right lung apex. What is the most likely histology of this mass?
Okay, working through the logic. Right-sided ptosis, constricted pupil, and no sweating is the classic triad for Horner syndrome. Combined with an apical mass, this is definitively a Pancoast tumor compressing the sympathetic chain.
Right.
Location defines the Pancoast tumor, but statistically, the most likely histology is non-small cell lung carcinoma, specifically squamous cell. Over 95% of them fall into that category.
Spot on. Question 2. A patient with a known history of small cell lung cancer presents to the emergency department with facial plethora, prominently dilated chest veins, and severe stridor. What is the most appropriate next step in management?
The facial plethora and dilated veins scream SVC syndrome, but the severe stridor is the alarm bell. Stridor means life-threatening central airway obstruction. The trap here is wanting to biopsy the tumor first, but you can't. The most appropriate next step is immediate endovenous intervention, like a stent placement or thrombus removal, along with airway stabilization. ABCs first.
You've got it. Final question. Question 3. A patient with a newly discovered central lung mass complains of significant difficulty standing up from a seated position. On physical exam, you note diminished deep tendon reflexes and sluggish pupillary responses, which finding on repetitive nerve stimulation is most consistent with the suspected diagnosis.
Difficulty rising from a chair is proximal muscle weakness. Add in the sluggish pupils and diminished reflexes, and we are looking at LEM, triggered by that central lung mass.
Right, the rusty gates.
Yeah, I'm thinking back to the rusty gate analogy on repetitive nerve stimulation. The most consistent finding is an incremental response at high read stimulation, proving that the weakness improves as calcium builds up with repeated nerve firing.
Flawless clinical reasoning. If you can logic your way through those, you are in incredible shape for the boards.
I feel vastly more prepared. But before we sign off, leave us with something to chew on, something a bit more provocative.
Consider this. We've just spent this entire session looking at how a mass in the lungs can perfectly disguise itself as an orthopedic shoulder joint issue, or a bizarre neurological weakness, or even a sudden vascular emergency.
Yeah.
It really forces you to take a step back. It makes you wonder, how many other idiopathic nerve or muscle complaints sitting in primary care waiting rooms right now waiting for a simple steroid shot are actually the very first whisper of a silent malignancy?
Wow, that is a chilling but crucial thought to keep our diagnostic minds sharp. We always have to look at the whole patient. Thank you so much for guiding us through the murky waters of pulmonary mimicry today. To everyone listening, keep pushing, trust your training, and good luck on your studying. You're going to do great.